You can manage that. I'm so much technologically
No, it
challenged.
is, yeah. Previously, during COVID time, I used to do quite a lot of this. So,
Mhm.
but now it's.
You can manage that. I'm so much technologically
No, it
challenged.
is, yeah. Previously, during COVID time, I used to do quite a lot of this. So,
Mhm.
morning, everyone. We are going to start our live symposium on liver disease and anesthesia. And we have uh, a an excellent faculty here today for various lectures. And this symposium will be led by Dr. Achal Dheer. Let me share his screen so that you all know something is not right here.
But we could see your screen.
You could see my screen. Okay.
Yeah, yeah,
Okay, 1 second again.
yeah.
Okay, so Dr. Achal Dheer will be leading this symposium. He is the ex-director of liver transplant anesthesia at London Health Science Centre, University of Western Ontario, Canada. And as is very obvious from these, his area of interest is liver transplant anesthesia and coagulation. He also has expertise in cardiac anesthesia and TEE. He has great interest in medical education, and he loves traveling and photography as well as his hobbies. And so, without much ado further, I would actually hand over to Dr. Achal Dheer, who will take us through today's symposium. With him, we also have Ashish and Tejal, who would be contributing to today's symposium. Over to you, Dr. Achal.
Dear Shiv, thank you so much for this excellent opportunity to share and gain knowledge from each other. And this is a perfect platform to uh, train our trainees, especially the postgraduates and people who do not work in academic centers. So our aim is to have this kind of symposium. So if somebody is in a remote area, suddenly has a patient who has got cirrhosis or some liver problems, and how to manage some practical tips and something of that sort. So thank you so much. And I would like to invite my couple of friends, great anesthesiologists, consultant anesthesiologists, and Tejal Desai. She is my colleague and working with us, and Dr. Ashish Malik, an excellent human being and person from Apollo Hospital, who would be joining us soon. So we have divided this symposium into three sections, starting by Ashish Malik, and he will talk on acute liver failure and acute and chronic liver failure, and perioperative management. After his talk, I will share my experience and what we have learned from liver transplants about the chronic liver disease. And finally, Tejal would be talking about management of patient with liver disease undergoing anesthesia for various types of surgeries. So without wasting much time, I would like to invite Dr. Ashish Malik to share his screen and start the session. Thank you.
Thank you, sir. And thank you, Dr. Shiv, for the kind invitation. I would just, I hope my screen is visible.
Yes.
So, as Dr. Dheer shared, I will be taking on the first shot in this symposium and talking about basically perioperative management of liver transplant in ALF and acute and chronic. So acute and chronic would also translate into acute liver failure. And at the outset, I just disclose that I have no conflicts of interest to declare for this particular presentation of mine. The brief outline on which I would be speaking on is what exactly is ALF, what epidemiology we know about, what is the definition, what perioperative approach do we take to handle these patients. Other than transplant, do we have some bridge therapy or liver assist devices? And what could be the prognostic models? And in the end, some key takeaway points, which I'll hope to concise this lecture. If you see the picture on the right, it's like a napkin, shriveled out napkin, which is the appearance of an acute liver failure. This is the first picture which was available from Guy's Hospital in 1839, what ALF looks like, what the liver looks like in ALF. So you look at the worldwide causes of ALF. If you look on the Western Hemisphere, United Kingdom or United States, acetaminophen is the most common cause of ALF. Whereas if you look on the southern part of the hemisphere, like India or the Southeast Asia, the viral load, at least in adults, takes more predominance. In children, on the other hand, the most common cause in Asia and South America is viral etiology. In North America and Europe, the 50% of these cases are indeterminate. And if you look at other causes, it could be Wilson's disease, it could be neonatal hemochromatosis, drug-induced, or HLL and autoimmune mitochondrial hepatopathy. Just to bring into picture how ACLF would present as an ALF is with the help of all these precipitating factors, which could lead to an acute decompensation. It could be infection, it could be alcohol-induced, viral hepatitis, drug-induced liver injury, surgery, and ischemia. So we look at what is the definition of ALF. It's a severe acute liver injury with no underlying chronic liver disease. If you see the transaminase levels, AST, ALT would be 2 to 3 times the normal limit. You would have jaundice, you would have coagulopathy, INR more than 1.5 with prolongation of PT. You could have a history of about 12 weeks post-jaundice, depending on the classification, and HE forms an important component, that is the hepatic encephalopathy in adult ALF. In pediatric ALF, on the other hand, hepatic encephalopathy is a non-essential component in children. So how do we divide this ALF? It is from the weeks of development of jaundice to the development of hepatic encephalopathy. And Ograndi et al. First published it Lancet in 1993. The hyperacute, acute, and subacute is the classification, and more than 28 weeks would be chronic liver disease. Hyperacute is the presentation within 1 week. Acute is between 1 to 4 weeks, and from 4 to 16, it could be subacute. If you look at the severity of coagulopathy, it's pretty high in hyperacute. Degree of intracranial hypertension would also be much more in hyperacute. But the chances of spontaneous recovery is very good in hyperacute, moderate in acute, and the etiology factor would be paracetamol mostly. On the front of acute liver failure, the coagulopathy, severity of jaundice, and degree of intracranial hypertension are more or less the same, and the etiology is mostly Hep B virus. The subacute, the severity of jaundice is much more high, and the prognosis is little difficult. Your spontaneous recovery chances are low. On the ACLF, what are the 3 major definitions which we have? They are, according to different societies, the APASL, which we in Southeast Asia follow, the ESAL, the European Association of Study of Liver and Chronic Failure Disease, and the North American Consortium. All these parameters which are taken into consideration is first the liver, that is the bilirubin level, kidney, whether it's acute kidney injury or the creatinine level, or in North American Consortium, whether you have a need for a renal replacement therapy. On brain front, the West Haven hepatic encephalopathy criteria is followed in all the three definitions. Coagulopathy would define as INR more than 1.5 in the parcel, and in the European Association, the INR is taken to be 2.5, whereas the North American does not mention. If you look at the circulatory aspects, shock takes a predominance in the North American Consortium, and as well as if you look at the respiratory parameters, the need for mechanical ventilation also forms a benchmark in North American Consortium. Whereas if you have the PaO to FiO2 ratio of less than 200, or the need of mechanical ventilation finds an important aspect in the European study, but not in APASL. So how do we look at acute liver failure? We could first of all go in for an optimal management, or that is what we all aim for. In terms of bridge therapy or liver support systems, we'll try to recover, and these patients usually have a very good recovery in many, as it will come later on in my presentation. This bridge therapy leads to liver regeneration. If this does not happen, we aim to move towards liver transplantation, and we look at the neurological, hemodynamic, and the biological recovery of organs in these patients. How do we decide which patients to transfer to the ICU? In case of paracetamol poisoning, we look at the following parameters: whether the arterial pH is less than 7.3, INR more than 3, presence of oliguria or elevated creatinine, altered level of consciousness, hypoglycemia, and elevated level of lactate, which is unresponsive to fluid resuscitation. In case of non-paracetamol cases of ALF, the pH less than 7.3 warrants an admission with an INR more than 1.8, oliguria and sodium level to be less than 130, encephalopathy, hypoglycemia, metabolic acidosis, and shrinking liver size on ultrasound. Then we move on to how do we approach and produce an assessment for these ALF patients. First of all, we need to establish the diagnosis. We need to recognize what is happening by history and clinical evaluation. We need to look at the etiology, the second part, why it has happened. So that is by help of investigations and history, and then evaluate the severity. In severity, we would look at what are the major organ-specific complications which might happen. So ALF, first of all, could attack the neurological aspect, leading on to cerebral edema, leading on to cerebral hypertension and brain death. On the pulmonary front, it will cause pneumopathy in terms of ARDS and pulmonary overload. Hyperdynamic circulation and arrhythmias are much more common in ALF, then has an infective potential. So you could have development of septicemia. Coagulopathy, it could lead to unbalanced hemostasis and as well as thrombocytopenia. And there are different metabolic derangements. And one thing which is of grave importance is the renal. They usually tend to have AKI, which could be functional or toxic. So what are the causes of mortality in ALF? In the years of 70s and 80s, bleeding was the most important cause of death in ALF. But now it has been taken over by multi-organ system failure due to endothelial cell dysfunction. It leads to circulatory collapse, respiratory failure, and renal failure. The other common causes are sepsis and intracranial hypertension, which lead on to a high rate of mortality in ALF. So what is our aim when we look at different organs? If we look at cardiovascular aspects and look at the early goal-directed therapy, we would like to maintain a CVP of between 8 to 12, that is with the help of crystalloids. We would like to maintain a mean arterial pressure of less than 60. If it is less than 65, we would like to make it more than 65, and with the help of vasopressors. And if we look at the SVO2, if it's less than 70, then we need to transfuse some bloods and have some inotropic agents through which the guide would be the PA catheters or other invasive cardiac monitoring. What happens in a cardiovascular system is that there is systemic vasodilation. There's a decreased effective cerebral blood volume. As of now, the literature has this kind of a background where we have listed, but there is no defined blood pressure target at the moment. And CVP has gone out of role. IVC diameter is something which is to be considered. Could or could not include hydrocortisone therapy. Whether it could help or not, that is still to be debated in literature. If you look at the respiratory system involvement, invasive airway management becomes a prerogative. which is followed by standard sedation and lung protective strategies. The aim is to avoid excessive hypercarbia or hypocarbia and avoid high PEEP. And the other aspect is that you could have aggressive chest physiotherapy. On the metabolic front, there is acidosis, hypoglycemia, hyponatremia. And you would have alterations in the magnesium, calcium, and potassium levels. Lactate elevation is found to be the most significant poor prognostic marker. And these are the parameters which could be corrected with early initiations of renal replacement therapy. So we move on to what happens on the renal front. AKI, 40 to 80% of ALF patients would have AKI. And this AKI is important because it leads to increased mortality and longer hospital stays. The parameters which need to be pointing an eye towards why high chances of AKI would be either paracetamol-induced ALI, or there is systemic inflammatory response, hypotension, infection, and increased age of the patient. So what is documented and is followed with hunters world over is early institutions of extracorporeal therapy, and we would like to have a continuous renal replacement therapy rather than intermittent hemodialysis. The literature is deficient in telling us what is the impact of this early institution of the renal replacement therapy. As of now, we only have about 4 RCTs, and all these RCTs are not limited to the liver transplant patients. It's either cardiac surgery or septic patients or patients in the ICU. But the early initiations of RRT has definitely impacted the mortality and has brought it down, which I have highlighted as a red bar in this. But we do need studies in liver transplant as of now. As an institutional protocol, RRTs are followed. See, the renal replacement therapy is started as soon as the patient is admitted with ALF. Then what happens to the coagulation? So the procoagulant factors are decreased. The anticoagulant factors are also decreased. But I wanted to highlight that the von Willebrand factor and the factor VIII, which are the red bars here, are increased in ALF. So you may have rapid changes in PT and INR, and all these values may not translate into coagulopathy. So, but the PT INR values have a significant prognostic value. What is common is thrombocytopenia and increase in the plasminogen activate angiotensin inhibitor also goes on increasing. So what is the guideline for bleeding diastasis? Prophylactic correction is not at all necessary. It is not mandated. The correction of INR actually obscures a critical indicator of spontaneous recovery and prognosis. There are no studies to substantiate the goal of correction of this, so we don't actually do it. What it could lead is this correction would lead to increase in risk of thrombosis and transfusion-related acute lung injury. The only indication to correct them is when we need to insert intracranial pressure monitoring or there is a chance of active bleeding. Otherwise, there's no indication to correct any coagulopathy in such patients. Then the risk of sepsis is also pretty high in ALF. It's a dynamic immune dysfunction. But what is advisable is the prophylactic antibiotics and antifungal agents have not found to have any survival advantage. We should start early antibiotics. That is, if the HE is progressing, if there are sepsis signs which are getting highlighted, and the antifungal therapy is also to be started if we anticipate a very prolonged critical care. So why hepatic encephalopathy happens? It's a neuroinflammatory disorder. It tends to fluctuate. It could be from trivial lack of awareness to deep coma. And the course is dictated by the outcome and the phenotype of the liver failure. What exactly do we look in hepatic encephalopathy? We look at the ammonia levels. And it has been well documented that the arterial ammonia levels of more than 124 millimoles shows about 80% of sensitivity and specificity predicting mortality. How we control them in the preoperative patients could be with the use of rifaximin, lactulose, acrobose, and probiotics. Then this cerebral hepatic encephalopathy leads to a very dangerous complication in ALF. That's intracranial hypertension. The mortality suddenly jumps up from 44% to 82%. And 1/3 of these cases are either grade 3 and grade 4. So they would require immediate elective intubation. And where is the risk high? Whether it's usually high in hyperacute and acute phenotypes, younger age group, patients where there's a need for inotropic support, and there is persistent elevation of arterial ammonia. This intracranial hypertension or edema, which happens, would lead to cerebral herniation and ultimately brain death. And it has a vasogenic and a cytotoxic origin, and ultimately leading to increased intracranial pressure. These needs to be monitored regularly in the ICU where the patient is admitted. That you have to have a neurological examination 4 to 6 hours. We take the help of ONSD. We take the help of transcranial Doppler. And as you see the cerebral oximetry, that is the arteriovenous difference of oxygen saturation. How do we manage the surges of ICP in these patients? Is with the use of mannitol or hypertonic saline, which comes to a mild hypothermia. And the quad 4 components or quad H components is, one is hyperventilation, then is hemofiltration, then hypernatremia and hypothermia. And do we have any evidence in literature? Yes. Class 1 evidence is mannitol and hypertonic saline. Class 2 evidence is for hyperventilation, hypothermia, and bioartificial liver. And then we actually practically don't use indomethacin, but it has a class 3 evidence, and propofol is used as a sedative agent in some patients. Then brings us to the idea of the intracranial pressure is rising. That means the pressure is more than 25 or cerebral perfusion pressure is less than 50. We need to bolt. We need to produce a conduit where the pressure goes down, where ammonia levels are still more than 150 to 200, and it is not dropping with the help of renal replacement therapy or fluids. The inflammatory response is high. That means the heart rate, the fever, and sodium is also low at presentation. These are all indicators when we need to have invasive intracranial pressure monitoring. So with this management of ALF in the ICU or the critical care, we need to have a tailored perioperative care. That means the transfer to the OT or the OR when the decision for transplant is taken. The patient has to be in a sedative and paralyzed state. There has to be no movement. The head elevation is about 10 to 30 degrees. We need to avoid mechanical ventilation. There should be a need. We have to assess what is the need for PEEP, maintain vasopressors, and have good IV or accesses. Advanced preparation needs to be done in the OR because these patients may be too sick, but they're likely to recover. So we have to maybe have an EEG or a renal replacement therapy, veno-venous bypass, things on which hypothermia could be induced, as well as the ICP monitor. And all these things also depend on the donor quality, especially if you are looking at the DDLT program. And the LDLT most or less may be defined, but you could have an extended criteria like the ABO incompatible, or you could have a much more fat component in the donor quality. And what intraoperative considerations are we bothered about? That is, first aim is about cardiovascular stability. That means having a good vascular access. Second aim is to keep the CMRO2 down by means of hypothermia. Use of viscoelastic tests is mandatory so that we don't need to overcorrect whatever coagulopathy is there. And in my experience, any INR or any value does not need any correction except when there is bleeding. Hypovolemia is not recommended. We need to have a strategy of low tidal volume with an adequate amount of PEEP in out to prevent acute lung injury, and intraoperative management with renal replacement therapy, as well as the surgeons need to be quick with early ligation and shunting and minimal handling of liver, and plus having a good graft. So what I would sum it up is like the John McEnroe approach. Be aggressive, be angry, you'll save this patient. Then we move on to the bridge therapy. What are the kind of, suppose liver transplant is not an option, do we have any liver support therapies? What we normally use is the high volume plasma exchange. Bioartificial liver devices in terms of ELAD and BAL are present. Then artificial liver devices in terms of Mars, Prometheus, and SPARE. So the indications for these support therapy is acute liver failure, acute on chronic, HRS with sudden deterioration, hepatorenal syndrome 2 with slow deterioration, post-liver graft dysfunction, post-apoplectic liver failure, and irretractable pruritus could also be there. So one of the first studies which gained importance was a Fulmer study. It was a randomized controlled trial, and the probability to receive transplantation was found to be much higher in paracetamol-induced ALF patients rather than the other causes. And you could see the recovery rate was also very high, about 80% in ALF patients due to paracetamol-induced ALF. In case of non, the recovery rate was about 42%. Then is the look at whether high volume plasma exchange, which is done in many centers, does it have an active role? It's an early intervention. So a randomized controlled trial where the HPV was studied against standard medical therapy. They found the survivability in which the plasma volume exchange was pretty high if you compare it with the standard medical therapy, because it reducing the damage associated molecular proteins. And we can also say that this is not strictly an extracorporeal system. And if you look at the discharge rate, again, with the use of high volume plasma exchange, the discharge rate was about 60% as compared to 48% in the standard medical therapy. Then there is another H2020 project, and this is being spearheaded by Dr. Rajiv Jalan in London. And this is a DILA, or it's like a dialysis system for liver. This system has been studied in detail in animal models, and the trials are now going on the human patients. It has led to improved survival, reduced endotoxemia, and improved immune function. And Oxaris and Septax are two common things. We have been using Oxaris in septic patients in ALF care itself in my center. The other aspects when you don't get a liver could be either we do a temporary hepatectomy, that we have induce a temporary anhepatic state, or with the use of veno-venous ECMO is also documented. The studies which are now being conducted and what would be looking towards the future is a functional artificial liver. That means the cells are being conditioned and stored, and ultimately there is something which is coming as suck liver. But there are certain issues, and maybe hopefully in 10 years' time, we might look towards a functional artificial liver. That leads on to what is the window of opportunity where we could shift our medical management to early transplant. If you see this figure, there's a concept of golden window. You see on the red bar, the window opportunity for ALF is pretty small as you compare it with ACLF. And it is quite high for a chronic liver failure. Once the patient crosses this window of opportunity, it becomes too sick for transplant. And below this window of opportunity, it is too early for liver transplant. So this is something of a judgment which you should be all aware of. If you look at the prognostic scores for ALF, the 4 criteria which we commonly use is the King's College, Clinchy, Bell score, and Apache. But King's criteria for ALF is well documented because the sensitivity as well as the specificity, if you compare with other kind of scores, is pretty high. The sensitivity is about 70%, and the specificity in different etiologies of liver transplant is between 82 to 92%. And what we actually look at is the age, the cause of acute liver failure, presence of encephalopathy, presence of coagulopathy, serum bilirubin, and serum creatinine levels. What are the prognostic factors which are poor is that if the INR is increasing, on ultrasound you have a shrinking liver, increasing bilirubin, and following of aminotransferases. They're all prognostic markers which are poor for further recovery. So there is a thin red line in where we need to go quickly and act and move towards transplant, and where we need to define whether it's a pre-transplant fatality. There is a consensus statement of 35 international experts published in Transplantation 2021. Delphi method was used, and they found that the major contraindications to do a transplant, because it's a scarce organ, is age more than 60, you have the CFS of more than 6, you have a PaO2 to FiO2 ratio of less than 150, then NOR-epi more than 0.6 to 1 microgram, lactate documented of more than 9, ongoing infection, and severe pancreatitis. If we put it into a pictorial representation, these are the red barriers where you will have a threshold. The PaO2 FiO2 ratio of less than 150, and then NOR-epi steadily increasing, and then serum lactates further increase. So what are considered contraindications to liver transplant can be either stabilized or you could improve the clinical course before proceeding. So before I end, I would share a little bit experience in my center of ALF patients between 2015 to 2023. What we found is that 40% of these patients in a subset of 198 had spontaneous survival. We found 30% of them underwent liver transplantation, and we lost 30% of the patients. Viral etiology was found to be most common, Mean extubation time was 3 days. We did renal replacement therapy for all these patients, pre-op, intra-op, and post-op. CT or the MRA was done in all of them. And the most common cause of mortality was multi-organ dysfunction. So I would say that this is, before an ending, this picture represents acute liver failure patients, and this is when the new graft is put. And I would say that severe liver failure has a very high waitlist mortality. There is a clear need for liver support systems. We still are scarce on literature, especially the randomized controlled trials on survival benefits. The future looks at biomarkers. Can we talk about cerebral inflammation, bowel failure, or any markers for AKI? And in hypoxic hepatitis, VA ECMO might have a role. So I end by saying ALF is a pitch dark night with two lights. Just to show you, the only thing is that you start running on your course of management like galloping of a horse. There are a lot of bends. If you can go around them safely, there is a big light at the end of the tunnel, and you will see that most of these patients recover, and it is very heartening and satisfying to see them recover from what they were. Thank you so much. And I end my talk here. Would be happy to answer any questions. Thank you.
That was excellent, Ashish. Wonderful talk and wonderful knowledge sharing. So I think we'll take the questions at the end of our session if there are any. And I will move on to second talk, which is mine. And I will share my screen now. Okay, thank you so much again. From what Ashish mentioned, which was state-of-the-art lecture, I will change gears here and come back to very basics. And my talk is more of understanding what goes on in patients with chronic liver disease, some key messages, because there have been some myths around this. And my talk is basically geared for junior trainees. I do not have any conflict of interest for this particular presentation. So we know basically our aim in life for every human being or every living organism is survival. And for survival, we need two things. One is continuous supply of essential vital nutrients, which is uninterrupted. And second, defend ourselves against any harmful agents or any invaders. And in life, we have two sources of nutrients coming in. One is by air, and the other one is through the ship or through the water channels. And for both these routes, we need to have some protective security agents here. For the air, we have the lungs, which are giving us oxygen, taking the CO2 out, at the same time protecting that whatever comes in does not go in if it is bad for us. And for waterways, for the portal system, we have the liver, and I call it the security agent. Whatever we eat and which is absorbed from the gut, whether it is food, water, toxins, alcohol, that has to get absorbed and go to the liver before it passes on to the systemic circulation. As we know, liver is the biggest organ in body, and it takes 25% of the total cardiac output. It is considered as one of the vital organs. It has more than 500 different liver different functions. So I will not discuss those in details, but one of the important thing is metabolism of carbohydrates, that is glucose, proteins, that is manufacturing of albumin and globulins, and metabolism of fats, producing cholesterol, and making sure triglycerides, everything is manufactured as required. In patients with liver disease, what happens? There is a malnutrition because patient is unable to, number one, absorb or digest that food because of lack of bile salts and bile acids. There is also deficiency of different vitamins because liver is a good source of storing these vitamins. The important ones for us is vitamin K, which is involved in production of various coagulation proteins. And of course, patient might also be anemic, and there may be iron deficiency and a whole lot of other deficiencies. Liver is a great source of giving us immunity and protecting us from any invaders from outside by producing various antibodies. So when the liver fails, the patient's immunity also goes down. Portal hypertension, which goes hand in hand with chronic liver disease, is a separate entity altogether. There can be portal hypertension without cirrhosis of the liver or chronic liver disease, but all chronic liver disease will have some degree of portal hypertension. Then, because of liver dysfunction, we may have different derangements in the body. Then there can be stigmata of the chronic liver disease. And lastly, there can be multi-organ dysfunction because of the chronic liver disease. The liver dysfunction itself causes because of hepatocellular damage. There will be increased bilirubin. The enzymes, both ALT and AST, will be high. If there is a cholestatic picture with chronic liver disease, there will be alkaline phosphatase and gamma GT would be high. And if the function dysfunction is bad, there is synthetic dysfunction. That means albumin would be low, bilirubin would be high, and there will be coagulopathy. Stigmata of chronic liver disease are basically because of low testosterone and increased estrogen. There is loss of hair, especially from the chest, axilla, and pubic hair. There is Palmer erythema, and there is gynecomastia and testicular atrophy. Organ dysfunctions because of chronic liver disease and portal hypertension are multifactorial, and they all affect the heart and cardiovascular system, brain, lungs, and kidneys, to name a few. So this is a little bit of data from our center. We started doing liver transplant in 1977. This is the indication of liver transplant. In the beginning, it was mainly the primary biliary cirrhosis and other multiple factors. Hepatitis C was a small portion, primary sclerosing carditis another small portion, alcohol and cancer were still there. Then moving forwards, next 375 patients up till 2005, the indications of the disease modality changes. And this also changes from different geographical locations. Now, in this era, we had the primary sclerosing cholangitis as a big one. Same was the hepatitis C virus infection. Primary biliary cirrhosis had decreased and alcohol was going up and up. Cancer was still the same as it was before. Coming to the modern era, last 960 transplants we did. Hepatocellular carcinoma, HCC, has taken the chunk of the chronic liver disease or indications for transplant. Another one is NASH. The name has changed to MASLD. This is non-alcoholic steatotic hepatitis, basically the fatty liver disease. That is coming a big way as an epidemic, and alcohol also is going up and up. If you look at the hepatitis C virus infection, which has come down drastically after the invention of direct antiviral agents. So we call a chronic liver disease when the disease or the jaundice proceeds more than 6 months. That is more than 24, 25 weeks of initial presentation of symptoms. There is a liver damage. We know that liver has a good potential for recovery and regeneration. It regenerates, but unfortunately, it comes out with lots of fibrotic nodules. In the initial stage, which is reversible by changing the lifestyle modification or doing some good stuff in body, choosing a healthy lifestyle. But if we don't, then ultimately leads to cirrhosis, which kind of is irreversible, but can be stable. So chronic liver disease in the beginning is pretty stable. Then there is compensated cirrhosis. It becomes decompensated when there are some index complications in the form of bleeding from the esophageal varices, development of ascites, encephalopathy, and jaundice. And ultimately, if we do not do something at this stage, patient would die. There are different ways to score our chronic liver disease patients. The age-old one is a child-Pew score, which takes into consideration bilirubin, albumin, ascites, encephalopathy, prothrombin time, or INR, and we grade them as 0.1, 2, and 3. Give these points. This has been going on for many years, and we classify as child-Pew A, B, or C when we total these numbers. There were some issues with this particular scoring system, as there were a couple of subjective things in it. If I go for rounds today and I see my patient has got mild encephalopathy and mild ascites, you go to the round and you see and you say the patient has moderate ascites and significant encephalopathy. So with that, the number would change. There was also the ceiling effect of bilirubin. Whatever it goes beyond 3, it will always remain 0.3. And ceiling effect of albumin. How low it goes, it does not affect the counting of the CTP scoring system. We also noticed early that if patient goes into renal failure, which is quite high incidence in these patients, if the creatinine is high, the mortality is very much high. So Mayo Clinic came out with this new criteria called MELT scoring system, which is a model for end-stage liver disease. And this is a formula available on various websites. It takes into consideration of creatinine, bilirubin, and INR. So initially, MELT score was started to have the mortality while waiting on the transplant list, but now it has been validated in different systems and different surgical things also. So it can pretty much reflect and tell you the mortality or expected course of the disease when patient comes for non-transplant surgery. So I have developed a couple of questions here, which I give it to my residents when they come on rotation. So regarding splanchnic circulation, features of portal hypertension include all of the following except: is it ascites? Is it hepatic hydrothorax, thrombocytopenia, or hypoalbuminemia? Given the type of format of this particular symposium, I don't expect people to answer with clickers or yes or no. So I'll just give the answer. The answer here is hypoalbuminemia, because albumin is manufactured by the liver. So it will be down if there is a chronic liver disease. It is not part of the portal hypertension system. So with portal hypertension, there will be ascites, and hepatic hydrothorax is just an extension of ascites. And thrombocytopenia occurs because of the big spleen, which chews up most of the platelets. So the answer would be hypoalbuminemia. So let us discuss about splanchnic circulation a little bit. So I'm not interested in the arterial supply of the gut. Of course, basically three arteries: celiac, superior and inferior mesenteric arteries. What we are interested is in the portal system, that is the venous side of it. Everything we eat, drink, or do anything take by mouth has to go through the portal system through the security officer, which is our liver. Whether we ate any toxins, drink alcohol, or regular food. So this portal system drains all blood coming from the lower esophagus all the way up to rectum and takes it to the liver. And liver takes care of and neutralizes the bad elements from here. So what happens with the chronic liver disease, with the formation of these fibrotic nodules, the intrahepatic resistance becomes very high, and the blood flow, especially the portal system, which is the venous system, becomes a little bit sluggish, and there is development of back pressure and the so-called portal hypertension. Just on a side note, portal system is defined as any system in which it starts from the one capillary system and drains into another capillary system before going to the systemic circulation. So there are three portal systems in body, two venous. Of course, this one I'm talking about is the portal system in the gut or in the liver. The second one is in the hypophyseal hypothalamus axis, pituitary axis. That is also venous. And third one is in the kidney, which is arterial system. We know there is afferent and efferent arterioles. So that is also a portal system. So let us come back to our discussion here. So with this increased pressure or back pressure in the portal system, and there can be some thrombosis in the portal vein as well. And the left gastric vein drains from esophagus. So there is development of esophageal varices. There is a back pressure. There are big, huge varices. And that is also the place where it connects to the systemic circulation. So there is a development of these varices, which can, of course, have tendency to bleed and cause major life-threatening hemorrhage. The splenic vein also is part of the portal system that with the back pressure becomes huge. So there is a large spleen. And as I discussed before, it starts chewing up those platelets and causing thrombocytopenia. Of course, there are other reasons of thrombocytopenia in a patient with cirrhosis, which I will discuss later. And what happens with this is there is so much of back pressure that the fluid starts leaking just because of hydrostatic pressure. It starts leaking into the peritoneal cavity, known as ascites. And as I mentioned before, hepatic hydrothorax is the extension of ascites. Wherever these the great vessels come from thorax into the abdomen, both aorta as well as inferior vena cava and few other, the fluid which is built up in peritoneum starts leaking through these holes and causes the hepatic hydrothorax. This is basically same as ascites and a big component of portal hypertension. After that, if the pressure keeps on building and there is no way left out, the body starts doing some angiogenesis and opens up some channels which were present in the fetal life or make some new with angiogenesis and called collaterals. So what happens with collaterals is there is a lot of vessels around umbilicus which drain the portal system into the systemic side. That means this also known as caput medusae, which is seen in the paraumbilical veins, like serpentine vessels around the umbilicus. But what the important thing here is the toxins and ammonia and all those poisons which are supposed to be going through the liver and got neutralized by the liver, they are now bypassing this liver and they can go direct to the systemic circulation, causing ammonia to go up to the brain and causing encephalopathy and various other systemic problems. So this is the hallmark of portal hypertension and splenic circulation. We know that splenic circulation or the blood in the splenic veins is not significant in a normal population, which is maybe about 5 to 10%, whereas a chunk of blood remains in our systemic veins. When we look at the patient with portal hypertension, the chunk of blood now lies in the splenic circulation or in the portal system, whereas the systemic veins are suddenly are devoid of this blood, so is the arterial side of it. So portal hypertension, there is overall increased blood volume, but that blood volume mainly is in the portal side of it. Another beautiful study from Scandinavia, they studied the abdominal as well as splenic blood volume in healthy controls. It was 1.6 liters of abdominal blood volume, and about a liter of splenic blood flow. Non-cirrhotic patients, but patients, the almost similar amount of abdominal blood as well as the splenic blood. Compared to the patients who had cirrhosis, the blood volume had gone up to 2.4 liters in abdomen, and splenic blood volume was 1.6 liters. Basically, what I'm trying to say is that these patients have extra amount of blood lying in their splenic system because of portal hypertension. It has two implications for us. And number one is when we go for TIPS procedure, which is one of the relieving factors for this portal hypertension. And when or at the time of liver transplant, when we release the portal clamps, this extra liter of blood goes suddenly into the systemic circulation within a couple of heartbeats, causing acute load and making the patient go into acute pulmonary edema or heart failure. So something to be considered of. Coming to the management of portal hypertension quickly, we know that the vasopressin receptors are more concentrated on the portal venous side than on the rest of the veins in the body or on the arterial system. So that means if we give any agent which works on these vasopressin receptors, will have beneficial effect. So that means the use of vasopressin or terlipressin, which is the synthetic analog of vasopressin, and it's a longer acting drug. So that will decrease the portal pressure. For these patients are given diuretics, basically for ascites, to decrease the ascitic volume. Norepinephrine midodrine is the oral form of norepinephrine, also helps in reducing portal pressure. Somatostatin analogs like octreotide has also been used to decrease the portal pressure. And lastly, recently it has been shown that statins, they preserve the endothelial function and thereby stabilizing it and decrease the portal pressure. For prevention of, I apologize, it should be variceal bleed. So for preventing esophageal varices to bleed, so ideally we do banding of these. We put the rubber band, or still some centers do sclerosing therapy by injecting some agent to make these smaller and go away. And we also give beta blockers to decrease the pressure in these esophageal varices, especially the non-specific beta blockers. Lastly, there are some surgical options. It was seen long time ago that whenever there is portal hypertension, there were some collaterals developing between the splenic vein and the renal vein. So this is how historically it started long time back, known as lino-renal shunt, where we connect the renal vein with the splenic vein and unload the portal system. After that came the central portocable shunt. So this is the portal vein, and this one is the IVC. So surgically with laparotomy, we open and connect these two and unload the portal system. But nowadays, TIPS, which is transhepatic intrapulmonary, transjugular intrahepatic portosystemic shunt, we put a shunt. This is totally go from the neckline and then intrahepatic, and put this shunt which connects the portal vein into the directly into the inferior vena cava. Lastly, and rarely, sometimes, not sometimes, I would say very rare, splenectomy can be done to decrease the portal pressure and to improve a little bit of platelet numbers. So coming to our circulation part. So question number 2, circulatory effects of end-stage liver disease include all of the following except. That means circulatory effect of the liver disease: increased cardiac output, increased systemic vascular resistance, increased heart rate, and downregulation of beta receptors. We know that traditionally chronic liver disease is known as hyperdynamic circulation. The blood pressure may be a little bit low, but the cardiac output is very high. There is suprasystemic, very high cardiac output. So the vascular resistance usually is very low because of the toxins. They are mainly vasodilators. So the systemic vascular resistance is low rather than increased. And of course, because of sympathetic stimulation, there is tachycardia. And because of chronic sympathetic stimulation, the beta receptors are downregulated. So coming to the second part, that is the effect of liver disease onto the cardiovascular system. There are going to be 4 different pathology where we see the cardiac disease in a patient with the liver cirrhosis. There can be common etiology which causes the liver cirrhosis as well as problem with the heart. That is hemochromatosis, Wilson's disease, collagen storage, amyloid, sarcoid, and of course alcohol also. Alcohol can cause cardiomyopathy as well as cirrhosis. Whereas there can be some independent cardiovascular disease, nothing to do with the patient's cirrhosis or liver disease. That is coronary artery disease, atherosclerosis, rheumatic or valve diseases. So your patient who is suffering from cirrhosis may also have rheumatic metal disease or something. Off note, I should point out that coronary artery disease is becoming very common nowadays in a patient with fatty liver disease or NASH cirrhosis. Because the causative agent is metabolic syndrome, patients are diabetic, dyslipidemic, hypertensive. So all the risk factors which will cause cirrhosis, which also will cause coronary artery disease. But more importantly, Cardiovascular dysfunction can be in the chronic liver disease due to cardiomyopathy, known as cirrhotic cardiomyopathy, or more commonly, circulatory abnormalities. So we know that there is much more vasodilators than vasoconstrictors in a patient with chronic liver disease. These patients are a little bit resistant to vasoconstrictors, and there is androgenic atrophy. On the other hand, vasodilators, they are produced much more. Mainly, they are from intestinal origin, which bypass the liver and go into the systemic side. But of course, there are some systemic vasodilators produced as well. So these, as mentioned, escape from the liver disease, from diseased liver, going directly through the collaterals or through the tips into the systemic side. And the patient is increased sensitivity to these vasodilators. There are so many labeled. To name a few is nitric oxide, carbon monoxide, and few others. So what happens to the circulation chronic liver disease? There is absolute volume overload. But this volume overload, as I mentioned, is more into the splenic circulation. And with increased arterial compliance and vasodilation, there is functional hypovolemia. And what does body think about this with functional hypovolemia? It causes sympathetic stimulation. So with that, there is increased contractility as we just measured that. There will be tachycardia. But that also leads to different other issues I will discuss in a second. So the total blood volume, the central component is decreased and non-central is increased. There is increased blood flow to the lungs and to the skin. So these patients, if you feel their pulse, which is bounding, they may be hypotensive, but pulse is very good. So we do not have any problem in inserting an arterial in these patients at least. But the blood flow to the brain and to the kidneys is decreased, and liver blood flow, depending upon what kind of resistance we are talking about, usually is decreased but can be increased as well. So the so-called hyperdynamic state in chronic liver disease, I give an analogy of Mr. Bean driving an old Volkswagen Beetle at a speed of 80 kilometers per hour and very happy, whereas a young, healthy liver with healthy heart and cardiovascular system is like a Tesla, but cruising happily at a speed of 40 kilometers per hour. This does not mean that Mr. Bean has a better car than Tesla. So what happens is with chronic liver disease, the cardiac output can be very high compared to the normal cardiac output, which is say about 3 to 5 liters, or cardiac index of say 2.4 liters per meter square per minute. Whereas end-stage liver disease or chronic liver disease, it is very high. The difference here is this cardiac output is at the flat portion of the Frank-Starling's curve, whereas the normal cardiac output in this particular patient, a person, is at the steep portion of Frank-Starling's curve. That means if we need to increase cardiac output, there is enough room to do so in a normal patient. Whereas in cirrhotic patient, their heart is beating very fast, cardiac output is very high. But if there is any stressful situation, this will not be able to increase further and will fail. This particular heart will fail. A typical example of this is one of my patients. Look at the cardiac index of 8.3 and cardiac output of 16.5. If I remember correctly, I think I have seen about 18 liters of cardiac output per minute, which is huge compared to a normal person. So what happens with continuous stimulation of beta sympathetic system? There is downregulation and desensitization. What happens is there's depletion of myocardial intraneural norepinephrine. There are raised epinephrine levels that continuously keeps beating these beta receptors. With that, the beta receptors go inside the cell surface. So there is a reduction in the density as well as impaired function of these beta receptors. So the so-called downregulation and uncoupling. Also, there is baroreceptor dysfunction of these patients. So ultimately what happens is the chronic liver disease patients have so-called chronotropic incompetence, meaning that if we send these patients for dobutamine stress echo to evaluate their coronary artery disease or so, these patients may not be able to achieve the target heart rate because their heart rate is already a little bit on the higher side, and there is no way we can increase because of the chronotropic incompetence. Similarly, there is inotropic incompetence. That means they will be a little bit resistant to conventional inotropes. If your patient is hypotensive, you may require more than the normal average doses of inotropes. Typical example I see, if I give a norepinephrine dose of say 5 mics per minute to a regular patient, this will probably maybe nothing in a patient with chronic liver disease. We may have to go up to say 10 or so. And because of the problem with the fluidity of the cell membranes, there is prolonged QTC, ultimately leading to reduced cell survival in the myocardium. There is inflammation and there is myocardial depression. So no way we can say that these patients' heart are really good. They definitely are hyperdynamic, but systolic function at rest is normal or supernormal. But this is under the conditions of stress, this systolic dysfunction is unmasked, which we normally see if we suddenly drain a large amount of ascites or hepatic hydrothorax, or patient develops infection in the ascites, that is spontaneous bacterial peritonitis, or if there is sudden bleeding from esophageal varices. So these patients will immediately go into hepatorenal syndrome and also in heart failure. And we know these patients have diastolic dysfunction, which is unmasked if we suddenly do a TIPS procedure. So coming quickly to about the central nervous system, I will not discuss in detail. Ashish has already discussed at length. So there is failed hepatic clearance of toxins and ammonia, and there's altered endogenous transmitters like GABA, glutamate, and nitric oxide in the brain. So with acute liver failure, there is high chance of cerebral edema with raised ICP, whereas in chronic liver disease, generally we see, because the process takes many years or a long time to develop, there is known as encephalopathy of different grades from grade 1 to 4. There can be sleep-wake cycle abnormality, patient may be confused, there can be tremors or fetal hepaticus, and there can be loss of consciousness or coma. Question 3, coagulation chronic liver disease in general is hypercoagulable, hypocoagulable, balanced, or hyper in early stages and hypo in severe liver disease. So this is an interesting concept I would like to discuss. The answer here is balanced. As Ashish also mentioned, the coagulation here is balanced, which may be very fragile balance though. So we know that on one hand, we may have patients bleeding to death, and on the other hand, we have patients dying because of increased thrombosis, either stroke, MI, or in other parts of the body. But the real balance in life is always having a balance between these two systems, one causing bleeding and one causing thrombosis. So if patient coming for stroke, or MI, we give TPA, some antifibrinolytic agent. Of course, it dissolves the clot, but there is tendency towards bleeding. And on the other hand, if patient is bleeding and we want to give some, in the past we gave aprotein prothrombin complexes or factor 7A, the patient may start clotting in some other parts. So ultimately, it is the balance which is a must. With DIC, what happens? Patient starts clotting at one side and starts bleeding on the other side. So which is the worst kind of situation. What happens in liver disease? The same balance is still there, but it is very fragile and very narrow. This can tilt to this side in one situation or to the other side and next day or very soon, depending upon what is the endothelial function and what we're talking about, like infection, inflammation, etc. So it is known that if we look at the hemostasis, there are three components. The primary hemostasis, which is stage 1, as soon as a vessel, artery or vein is cut, there is vasoconstriction, then these platelets attach to the vessel wall and causing a platelet plug. This happens because of the tissue factor coming from the external, from the outside, and von Willebrand factor, which is in the endothelium. So that is a stage 1 of hemostasis. After that, on this platelet plug, all those blood coagulation factors, they start acting. So I call it that these coagulation factors play on the platelets, and platelets serve as a playing field for them. And there is generation of thrombin because of different coagulation pathways and cascades, internal and external things. Ultimately, the clot is formed, bleeding is stopped. At the same time, we do not want this clot to close our artery or vein permanently. There is fibrinolysis, which is clot dissolution. So all these three components of hemostasis are crucial. So there can be anti-hemostatic drivers, or there can be pro-hemostatic drivers, but this balance is a must. Little bit about platelets in liver disease. As I mentioned, because of hypersplenism and portal hypertension, this is one of the common cause of decreased platelet count or thrombocytopenia. Second is thrombopoietin, which is manufactured in the liver, is low because of the liver disease. And sometimes there is a bone marrow suppression because of different disease states or because of the liver disease as such. So liver disease will have low count of thrombocytes. However, I call these platelets as super platelets, which I will discuss in a minute because of the von Willebrand factor and factor VIII, which make these platelets stick to each other, and they are very powerful. So we know that all clotting factors, but with the exception of factor VIII and von Willebrand factor, are produced by the liver. So that means when there is a liver disease, all clotting factors except these two will be low. In fact, there will be a compensatory increase in these two factors, and this is why the platelets function very effectively despite their number being low. At the same time, with the liver disease, all natural occurring anticoagulants, which are antithrombin 3, protein C and S, and tissue factor pathway inhibitor, they are all also manufactured by liver. That means that whenever there is liver disease, which does not discriminate between the clotting or anti-clotting factors, so both factors would be low, both anticoagulants as well as the clotting factors. Lastly, all fibrinolytic proteins except tissue plasmin activator and plasminogen activator inhibitor are also produced by liver. So that means these two will go up. So that means there is a balance even in liver disease of both these pro as well as anti-hemostatic factors. Look at this particular enzyme, ADMATS. This is an enzyme which destroys the von Willebrand factor, which is very important in the stage 1 of the hemostasis, that is platelets sticking to the vessel wall, as well as activating factor VIII. So if we look at this activity of this particular enzyme, if this enzyme is normal, it will keep on metabolizing this von Willebrand factor. But when the enzyme is low, which we see in chronic liver disease states, as the liver disease worsens, this particular enzyme becomes less and less. That means decreased activity means increased von Willebrand factor. That means increased the tendency for clotting or clot formation. So coming to the liver disease, so on one side there is thrombocytopenia. There can be a little bit of platelet abnormal function, decreased thrombopoietin, and increased nitric oxide and prostacyclin. But to counteract this, there is elevated levels of von Willebrand factor and factor and low levels of the enzyme which degrades this von Willebrand factor. Coming to the second stage of hemostasis, that is the clot formation. There is low levels of all these factors except factor VIII, which is increased, but there is also reduction and normal anticoagulants in the body. So these balance out each other. Lastly, the fibrinolysis also kind of tends to balance each other, but many times we see that these patients may have increased fibrinolytic activity. Clot does form, but that may not be as stable as we need to be. Another beautiful study, they studied the levels of factor 2 and factor 5 in healthy subjects, which is 100%. And as the disease progressed, liver disease from childs A, B, and C, there is for successive decrease in the levels of these factors, which are procoagulant. If we looked at factor 8, again, normal was 100% in average adults, healthy subjects. But as the liver disease started progressing, the factor 8 levels started going up. Again, to go to my point that the coagulation system in these patients is balanced. Look at the protein C and protein S, which are antithrombin levels, which are the normal anticoagulant. These are the levels start becoming low and low as the chronic liver disease progresses. Again, this was discussed by Ashish also in acute liver failure, 20 patients, acute liver failure. This was study done in London, England. And these patients out of 20, 4 were found to be hypocoagulable, only 4. 9 had normal coagulation and 7 were hypercoagulable. And look at these, all these clotting factors, their number was low, except one Willebrand factor and factor VIII, which was high, and anticoagulants were also low. So this is a picture depicting that in normal health, the hemostasis is very well balanced. There is enough room to wiggle around on both sides. Whereas patient with cirrhosis or chronic liver disease, the balance is still maintained, but this is very fragile balance. If it tilts toward this side, patient starts bleeding. If it tilts to this side, there can be hypercoagulable state. So we have to be very careful and we should be wary of this. Couple of examples of my patients for liver transplant. This is a patient which is hypercoagulable. Look at this graph. This is a normal black line. This is going out of that. This is a hypercoagulable. This is a hypercoagulable patient. Another patient, this is a patient, very interesting. INR was 1.7, platelet count was 60,000, but this was hypercoagulable patient. So in fact, we had to give a little bit of heparin to bring it back. Otherwise, we don't want any clot developing in the heart or anywhere in the body. So it is generally said that platelet count of 50,000 is enough to produce enough clot formation. This is another interesting patient we had when the clamps from the liver transplant came off. We have a massive pulmonary embolism. Look at the clot filling the right side of the heart, right atrium, right ventricle full of the clot. This is just to give you an example that the coagulation in liver disease is balanced. Coming to the pulmonary complications quickly, there are 3: hepatic hydrothorax, hepatopulmonary, and portopulmonary hypertension. This I already discussed. This is just like an ascites. Hepatopulmonary syndrome is basically a vasodilatory state. There is formation of intrapulmonary vascular dilatations. In a normal, healthy subject, the pulmonary capillary is 1 RBC thick. So the 1 RBC can get rid of CO2 and takes oxygen. With vasodilation, there are multiple layers of RBCs which may or may not participate in the gas exchange. And with these intrapulmonary vascular dilatations like small aneurysms, there are layers and layers of RBCs which basically bypass this oxygen gas exchange method and cause right to left shunt. So this is a typical example of intrapulmonary right to left shunt. So this is type 1 hepatopulmonary syndrome. And sometimes there is actual formation of AV malformation connecting directly to the right side onto the left side. So this is this is type 2 of hepatopulmonary syndrome. If you look at the pulmonary pressures in liver patients, normal, we have normal cardiac output, BP, pulmonary pressures, and resistance. If there is a true portopulmonary hypertension, the pulmonary capillary wedge pressure and cardiac output are normal, but there is elevated pulmonary vascular resistance, which is causing elevated pulmonary pressures. But most of the time we see, because of hyperdynamic circulation of a chronic liver disease, there is increased PA pressure and cardiac output, but the pulmonary vascular resistance is normal. Lastly, rarely we also see patients with pulmonary venous or post-capillary hypertension. The problem is the left side of the heart. In that case, the pulmonary wedge pressure would be high, and cardiac output and pulmonary vascular resistance is normal. So with hyperdynamic circulation, with increased pulmonary blood flow, there is repeated microembolization. Systemic immune response plays a big role, and humoral pulmonary vasoconstrictor substances leading to intimal proliferation, medial hypertrophy, and fibrosis, ultimately leading to fixed obstruction in the pulmonary vasculature, causing portopulmonary hypertension. A last part of discussion is AKI in chronic liver disease. Basically, every renal failure is not labeled as hepatorenal syndrome in these patients. 1/3 of these patients are pre-renal because of aggressive use of diuresis, because of ascites or hypovolemia. And 1/3 of these patients can have actual acute tubular necrosis because of nephrotoxic drugs and use of IV contrast. And 1/3 of these patients have actually the so-called hepatorenal syndrome. And this is precipitated by large volume paracentesis, spontaneous bacterial peritonitis, and varicose bleed. The diagnosis of hepatorenal syndrome is mainly of exclusion. When we exclude these two, patient is in acute renal failure, and these two are not there. And then we say, and there are a couple of other parameters as well, of course, to diagnose hepatorenal syndrome. Treatment is IV albumin infusion, octreotide, terlipressin, midodrine, and we should always avoid non-steroidal. This is the again key take message that we should be giving them regular Tylenol. Of course, Tylenol we knew can cause Tylenol toxicity and liver failure, but for pain management post-operative, we should avoid at all cost giving them as non-steroidal anti-inflammatory drugs. So to conclude my talk, portal hypertension leads to ascites and hepatic hydrothorax, development of esophageal varices, collaterals, and that lead to toxins coming into the systemic side. There is a so-called hyperdynamic circulation, but this hyperdynamic heart becomes dysfunctional under the stressful conditions. Coagulation system is rebalanced. Of course, that is very fragile balance. Some patients may be hypercoagulable, so we should always give them thromboprophylaxis. We should not consider them the old age saying that these patients are auto-anticoagulated. If you're doing a patient for any surgery like laparotomy something, so think of thromboprophylaxis. Platelet count above 50,000 generally is okay. We don't need to give platelet transfusion. Be aware of hepatopulmonary, portopulmonary hypertension, and hepatorenal syndrome. And post-op, these patients usually go into renal dysfunction and infection because they have low immunity, and avoid non-steroidal anti-inflammatory drugs. And thank you so much. And I apologize for going a little overboard. Thank you. So now I would request Tejal to present her lecture on anesthesia in liver disease. Tejal, over to you.
Achal, can we give a brief introduction to Tejal as well, please?
Sorry, yes, of course. So Tejal is from Mumbai originally. Then she worked in Ireland and had anesthesia training there, and then came to our center to do fellowship in liver transplant. She was so good that we offered her a job, and she's now our colleague and involved with not only liver transplant, but general surgery, orthopedic, and other surgeries as such. And so she's an assistant professor in our department and a wonderful colleague to work with. And she's going to talk about anesthesia and liver disease. Thank you, Tejal.
Thank you, Dr. Dheer, for that kind and lovely introduction. And just to carry on with your talk, a lot of the concepts from your talk will be in my talk, but you've explained them very nicely, so I will not go through them in much detail. But today I'm going to talk about anesthesia in liver disease. We've got a good base with the pathophysiology in chronic liver disease by Dr. Dheer. And when these patients present to us, we need to be able to assess them and see what is the best approach forward for these patients. So chronic liver disease is a big problem that's facing us at the moment. There are the latest global statistics from 2023 suggest that liver disease cause death in about 1 in 25 people. Chronic liver disease is the 11th leading cause of death. In Canada, where we practice, it's a silent epidemic that's affecting 1 in 4 Canadians. And the top 3 causes of end-stage liver disease are alcohol excess, MASLD, which was previously known as non-alcoholic fatty liver disease. And that definition was taken away because it was stigmatizing. And also, many of these patients who have this cirrhosis are not necessarily obese. So that's why those definitions were taken away. And also viruses are the top 3 causes of end-stage liver disease in the world. Now, these patients can be presented as compensated cirrhosis, where you would not, they have no symptoms at all, but these patients are seen incidentally when they come in for laparoscopic surgery, and you will see a nodular liver, or they're having an ultrasound for some other issues, and then you find out that these patients have like a nodular counter on the liver, they have some varices. So these compensated patients are somebody that slip under the radar, and they might present to you in a decompensated phase. The rate of conversion of compensated cirrhosis to decompensated cirrhosis, I don't know why this is, to decompensated cirrhosis is about 4 to 12% per year. And the cardinal event where compensated becomes decompensated is the development of severe portal hypertension, which is the transition from compensated to decompensated disease. Okay. So the objectives of our talk today would be to understand the stages and nomenclature of chronic liver disease, risk stratify these patients who come in for non-hepatic surgery, and also anesthetic considerations specific to these patients. So when we talk about cirrhosis, it's the final common pathway for most forms of chronic liver disease. And it's irreversible scarring of the liver that happens with chronic inflammation. But the normal liver passes through certain stages, which can be reversible before the patient goes into cirrhosis, which is also known as end-stage liver disease. At this stage, the patients may develop hepatocellular cancer, for which they would need a liver transplant if it's not metastatic. And this stage of steatotic liver, where it's just fat accumulation in the liver, this stage could be reversible. Then it leads to a stage of inflammation, and finally the stage of cirrhosis. Now, this end-stage liver disease is a spectrum which is based on the degree of liver dysfunction and associated effects, multi-organ effects as well. So when you have compensated cirrhosis, you might have mild portal hypertension, you might have varices which are really small. When the patient becomes decompensated, you will see ascites, you will see hepatic encephalopathy. You might have a patient with varicose hemorrhage presenting to you. And even this decompensation, there is a further spectrum where there could be a late decompensation where you have refractory ascites. It's not responding to treatment. You have developed hepatorenal syndrome. You have recurrent episodes of hepatic encephalopathy. And you also have jaundice, and this ultimately culminates in death. So if you have compensated cirrhosis, your survival is about 12 years. But if you have decompensated cirrhosis, your median survival is only 2 years. So these patients are very sick. Okay. So this is a case of a 60-year-old gentleman with who came to us for inguinal hernia repair. He had some discomfort, some cosmetic concerns, and he was for surgery a couple of days later from the pre-admit clinic. There was a mention of cirrhosis, but when this patient was examined, he had ascites, he had a tense abdomen, he gave a history of previous varices, he had synthetic dysfunction in terms of a raised INR, and he also had jaundice. So it's not enough to know that this patient has a history of cirrhosis. What we need to know is, where does he fit on that spectrum of end-stage liver disease? So he fit right here. So he was decompensated, but it wasn't a late decompensation. It wasn't a late decompensation. So now when we have such a patient presenting for surgery who looks sick, the next question is, do we proceed with surgery, or how do we optimize this patient? Okay. So for the preoperative evaluation, Dr. Dheer mentioned some risk scoring systems. And the oldest one that we use is a childhood score, which was initially developed in the 1960s and modified in the 70s. As he mentioned, there's a ceiling effect. This is quite subjective, but we still use the classes A, B, C to categorize our patients that come in for surgery. We have some better tools to evaluate our patients preoperatively, and one of them is the sodium MELD score, which was published first in the early 2000s. And then a modification was done to it with the addition of sodium, because these patients can be quite hyponatremic. Hyponatremia was also a predictor of independent risk factor for mortality in these patients. So that's the sodium MELD score. Now, as he mentioned, it's a logarithmic score which uses the INR, bilirubin, and creatinine. And there are online calculators where we can use to calculate our patients and say, oh, what is their 3-month mortality? So in our patient, he had quite a high MELD score, which was 21, and his 90-day mortality was estimated to be 7 to 10%. Now, in addition, what the sodium MELD does not recognize is the degree of portal hypertension. Now, the other, it is up to 40, and when the MELD score increases more than 40, there's a 71% observed mortality. While when it's less than 9, then you have a 1.9% observed mortality. The next score that we have is the vocal pen score, which was recently developed just a couple of years ago and validated to estimate perioperative risk in patients with cirrhosis. Now, in addition to, it had some other variables as well that were added. So one is the ASA class. So you had a higher weight for a higher ASA class, obesity, the etiology. So if the patient has a history of MASLD or non-alcoholic fatty liver disease, then they got a higher points. Emergency procedure versus also the type of surgery. So this scoring system has a good calibration for postoperative mortality. So with this, when we put this patient's parameters in our vocal pen score, we got a 30-day mortality of 5.5% and a 90-day decompensation of 17.3%. Now, what is the relationship between MELD and mortality? In one of the earlier papers from 2007, they found that if the MELD score increased more than 8, then there was a slight inflection to mortality. So the mortality started increasing after the MELD score was more than 8. Then there was another recent paper which showed that in patients coming in for emergency general surgery patients, if you had MELD scores of less than 10, the survival was much higher than higher MELD scores. The median survival after surgery, when you calculate the MELD score, if you have a MELD score of 12 to 15, the median survival is only 1.6 years. So the MELD score does correlate well with postoperative mortality. Now, when these patients come to us, we have to risk stratify them. So for risk stratification, we use all of these. So this is a paper from last year. And in this paper, they have used the child Turcotte score, the ASA class, the MELD, the vocal pen, and the hepatovenous portal gradient. So more than 16 of this gradient is an independent risk factor for mortality and the type of surgery. So they've categorized that if the MELD score is less than 2, it's a low-risk surgery, the patient has a low ASA status, you can proceed surgery. But you need to discuss the risk of surgery, the post-op decompensation with the patient and the relatives. If the MELD is between 10 to 15, it's a gray area. And if the patient is high-risk surgery, then you might want to use certain measures to help in risk reduction in these patients. If the MELD is more than 15, the patient is ASA 4 or 5, it's a child book score C, and a high-risk surgery, then you might want to defer surgery and consider alternatives or even palliation. In this middle category, because the sodium MELD is heading towards the MELD, which is a cutoff for transplant, you might also work up the patient for liver transplant. And I will tell you why. Okay. This was another risk stratification algorithm from 2016, and this is from the AASLD, which is the American Association for Study of Liver Disease. And in that, they say that if a MELD is less than 10, proceed to the OR. If it's 10 to 15, and the patient has portal hypertension, you might want to, again, reduce the risk due to the portal hypertension. But if it's more than 16, consider alternatives to surgery and work up for transplant. Now, if you have, but this is only in elective surgeries. If you have emergency surgeries, what are the contraindications for elective procedure? Contraindications for elective procedures in liver disease. So if it's emergency surgery, you would proceed, but there are certain contraindications. So you could, if you have acute liver failure, acute viral hepatitis, acute alcoholic hepatitis, acute renal failure, hypoxemia and cardiomyopathy, you might not want to proceed with surgery in these patients because the post-op mortality is very high. Now, in patients who have higher MELD scores and higher childbirth, the post-op mortality is about 4 to 10 times higher, and complications also 5 to 7 times more frequent. Now, when we categorize patients as surgical risk, the literature says that low-risk surgeries are surgeries which are laparoscopic surgeries, so lap cholecystectomy, lap appendicectomy, abdominal wall surgeries, inguinal hernia repairs, umbilical hernia repairs, and orthopedic surgeries are considered low risk. High-risk surgeries would be open abdominal surgeries. For example, colorectal surgeries have an increased mortality in these patients. Major complications can occur, reoperation rate is very high. Cabbage and valvular surgery have approximately a 5-fold and a 7-fold increase of mortality in cirrhosis postoperatively, respectively. Thoracic surgeries are also considered high risk. Even though orthopedic surgeries are considered low risk, these patients are more likely to experience postoperative hemorrhage, surgical site infection, and need for revision surgery for patients who are undergoing joint replacement. Now, how do we do risk reduction? So in these patients, if you deem a patient who has a high MELD, who can be optimized prior to surgery, you can refer them to your hepatology colleagues or refer them to a higher center so that they can have some risk reduction. For example, if they have ascites, they might need to be on diuretics. They might benefit from a TIPS procedure if they have refractory ascites. If they seem to be encephalopathic, they need to be started on lactulose and rifaximin because postoperatively they are at a risk for hepatic encephalopathy as well. To reduce the portal hypertension, they need to be started on a beta blocker. And if they're intolerant to beta blockers, because these patients are very vasodilated, sometimes they do not tolerate these beta blockers, you might even consider variceal ligation, band ligation, just to reduce the risk of bleeding, but that does not reduce your degree of portal hypertension. Okay. Now, anesthetic considerations, one thing is the risk reduction that we spoke. So we can send them for risk reduction to get them better optimized if they really need to have surgery. Workup wise, we need to do a coagulation assessment, liver function tests, cardiovascular assessment, pulmonary considerations. And also, in addition to our usual blood work, we would also need specifically to look at hyponatremia and also look at the renal function, because these patients the patient that I spoke about already had a creatinine of 150, which is in micromoles. So he could be developing an HRS AKI due to his chronic liver disease as well and his ascites. Now, what about coagulation in these patients? As Dr. Dhir discussed, there are parallel changes in both pro and anti-hemostatic pathways, which leads to a rebalanced state. However, if you look at the diagram, as from early compensated cirrhosis to late decompensated cirrhosis, you find that the balance goes more towards a hypercoagulable state. And this is worsened by clinical events like AKI, bleeding, or infection. But whenever you have patients where you do an invasive procedure or surgery, this balance can be tipped either way. Now, usually you have patients who will come in with an INR of 2.3, platelets 47,000. Now, in these patients, though you find a high INR in these patients or APTT is high, spontaneous bleeding complications are not that common. And when they occur, they are as a result of portal hypertension rather than deranged clotting. So these in vitro tests are misguiding us in a way. The way to go about this is, if you have access, if you're in a higher center like we do, the point of care tests give you a better idea of where the patient is with the coagulation. So so INR, I want to restate that it is a indication of hepatic decompensation, dysfunction, and prognosis, but does not indicate that the patient is going to bleed. And in fact, multiple papers mention that prophylactic fresh frozen plasma should not be given to these patients just to correct that INR, because it significantly increases their portal pressure, increases the risk of bleeding, and also can lead to volume overload in these patients. In terms of the platelet count, values more than 50,000 may be associated with higher risk of bleeding, but because of the mechanisms that Dr. Dhir spoke about, that these platelets are super platelets, even when these patients come to us for liver transplants, we only give platelets based on the clinical picture and what the thromboelastography reveals. These thromboelastography or ROTEM are more physiological assessment of coagulation, and we commonly use those for our patients. One of the papers mentions to give thrombopoietin receptor agonist to patients who are coming in for invasive procedures. However, if you need it urgently, these are going to take a few days for them to work. And platelet transfusion should be considered for patients with platelets around the 50,000 or less mark if they have intracranial bleeding or a major surgical procedure. Now, as I mentioned, there's a big disparity between these in vitro tests and our point of care tests. So this is a TEG tracing from a patient who had, this TEG tracing, for those who don't know, is normal to hypercoagulable. It's absolutely normal to hypercoagulable, in fact. But in this patient, in the same patient, at the same time that the TEG was done, the INR is 2 and the PTT is 48. So they don't absolutely correlate. But what the TEG does, it helps us manage transfusions in these patients in such a way that we are not transfusing them unnecessarily. So it has the use of viscoelastic testing in studies have shown to reduce the transfusion requirements in these patients transfusion requirements in these patients. This is the same patient that Dr. Dhir showed about the clot. So this patient is the same patient with this TEG and this INR PTT who went on to develop that intracardiac clot in our patients. Now, cardiovascular assessment, we spoke about cirrhotic cardiomyopathy, where there is a systolic dysfunction due to impaired myocardial contractility. There is a poor response to stress and altered diastolic dysfunction. So a baseline, whenever these patients come for major surgery, a baseline echocardiography must be done. A 12-lead ECG will reveal that these patients may have a QT prolongation, these patients, 25% of end-stage liver disease patients come to us for liver transplants. But what we find is that they have some degree of coronary artery disease, which is usually moderate but asymptomatic. And in these patients, if they're symptomatic, now if they are coming for a orthopedic procedure, we need not do a coronary angiogram if they're asymptomatic. But when they come for liver transplants, we do a myocardial perfusion scan, which the limiting feature of a myocardial perfusion scan is that these patients are maximally vasodilated. So sometimes it is not of value. The other thing is a dobutamine stress echo, where they have chronotropic incompetence, so the target heart rate might not be reached, so it's not very sensitive. So hence a coronary angiogram, whether it's non-invasive or invasive, becomes the most accurate assessment of coronary artery disease in these patients. Next is pulmonary assessment. Now, these patients have a hepatic hydrothorax, which usually does not require drainage unless the patient is symptomatic or hypoxic. And usually we would order a chest X-ray for these patients. Because of the ascites, they're very high risk of pulmonary aspiration. So we do not do any procedure under sedation for these patients. We always do a general anesthetic and endotracheal intubation, and we use a rapid sequence intubation for these induction for these patients. If the patient shows if the patient, when seen in clinic or on the ward, if the patient is an inpatient, is hypoxic, then we should rule out hepatopulmonary syndrome or portopulmonary hypertension, because these for hepatopulmonary syndrome, the only treatment is a liver transplant, but it still takes few months for the patient's dilated vessels to come back to normal. And for portopulmonary hypertension, these may be referred to transplant cardiologists or respirologists to manage their pulmonary hypertension before surgery. Now, this is a patient, I chose this X-ray because this is a patient who had refractory ascites, who came to us for a TIPS procedure, and she has a significant pleural effusion on the right side. When she came in for surgery, we did not drain it because she seemed quite, she was not hypoxic, she was not in respiratory distress. However, a few days later, she did develop complete collapse of the lung on that side. So then she underwent a thoracocentesis. These are just HPS diagnostic criteria, which Dr. Dheer has already mentioned, but this is just for the state of completion. Now, next thing is, when we do an anesthetic for these patients, we have to be mindful of hepatic drug clearance. Now, hepatic drug clearance depends on intrinsic clearance of the hepatocyte, which can be defined as the sum of all enzyme and transport activity involved in hepatic metabolism. Second thing is hepatic extraction, which depends on blood flow. Now, this blood flow is reduced because of the portal hypertension, so the liver perfusion is reduced. Now, if you have a hepatic extraction, drugs which have a high hepatic extraction, which is fentanyl, sufentanil, morphine. So those patients, whenever you inject a drug, they will have a high plasma concentration because of the hepatic extraction, which is dependent on blood flow. Whereas drugs which have low hepatic extraction, it would be similar, the plasma concentration would be similar to healthy individuals. The other consideration is unbound drug as well. So patients, drugs which have high protein binding would also lead to high concentrations. Now, in terms of the anesthetic agents, sevoflurane, isoflurane, desflurane undergo minimal hepatic metabolism, so they're all safe. In fact, desflurane is the one that causes the littlest change in hepatic blood flow, because general anesthesia itself reduces hepatic blood flow by 30 to 40%. Now, when you talk about metabolism of anesthetic drugs, there are two main processes. One is by the cytochrome P oxidases, and one is glucuronidation or glycosylation. Now, because hepatic perfusion is impaired in end-stage liver disease, the oxidative mechanisms are more affected than the glucuronidation. So a dose reduction will need to be done in certain drugs which undergo this oxidative metabolism. And those drugs, sorry. And those drugs would be midazolam, diazepam, and clonazepam. The other benzodiazepines, which are minimally affected by liver disease, would be lorazepam and temazepam. Of the neuromuscular blockers, all of them have a longer elimination half-life in end-stage liver disease patients. However, atracurium, cisatracurium are not affected because metabolism is independent of the liver. As I mentioned, fentanyl, sufentanil can have high plasma concentrations. Will have high plasma concentrations because of the high extraction of these drugs. However, I would like to say about the drugs is that even though end-stage liver disease alters hepatic extraction, renal excretion, and serum proteins, the net effect of these changes on drug metabolism and elimination are unpredictable, making general recommendations for administration of drugs quite challenging. The next thing is fluid management. These patients are quite fluid overloaded. They have hyponatremic, but they're hypervolemic. So fluid therapy should be guided by dynamic measures like stroke volume variation versus CVP. Invasive blood pressure monitoring is recommended in most of these patients. We can safely inform MAPs of 65, which are adequate for organ perfusion, most commonly liver perfusion. For fluid resuscitation, balanced salt solutions like Plasma-Lyte or Ringers can be used. And albumin is indicated to prevent post-paracentesis circulatory dysfunction in these patients, especially after ascitic tapping. Albumin is used to prevent this circulatory dysfunction. Hemodynamic management can be guided by Swan-Ganz and transesophageal echocardiography in certain situations. For example, if the patient has portopulmonary hypertension, then these can be used. If we're having major surgery, as I said, the coagulation balance can tip anytime. So rapid infusers should be available around. And there should be a low threshold to start vasopressors. Now, this is just a picture of the splanchnic circulation where there is increased compliance of the circulatory system, and hence there is pooling of blood in the splanchnic vasculature. So you might have a low CVP in these patients, but all the volume is sequestered in the splanchnic vasculature. So in these patients, I think Dr. Dheer was speaking about vasopressin. We can move that blood into the central volume by starting them on vasopressors. Now, is regional anesthesia appropriate in these patients? Central neuraxial blockade can be used, but it has to be guided by the same cutoffs that we have from the international guidelines for coagulation parameters. For example, platelets above 75,000 and INR less than 1.4. So the same parameters should be used in these patients. Where possible, interfacial plain blocks can be used because these blocks, we do not have a risk of spinal hematoma. So there's no concern with that. So these can be used. Now, pain control with regional anesthesia can reduce the risk of hepatic encephalopathy and also the risk of respiratory depression associated with opioids in this group of patients. Also, viscoelastic testing guidance can be used to guide our regional anesthesia techniques. Now, in our institution, we commonly use tab block catheters, which we started initially for liver resection patients. We do it for all general surgery cases, and we also do them for our liver transplant patients. So because of the risk of accumulation of local anesthetic in this group over a period of few days, we are very mindful of the dosages that we use. And we use them solely in the form of boluses, which we continue for about 5 days. We also have institutional guidelines where nurses are trained to look for symptoms of local anesthetic toxicity. Pain management after surgery in patients who have cirrhosis, our first line is always acetaminophen, but we need to be, or which is paracetamol, but we need to be mindful of the dosage. Usually we would not exceed 2 to 3 grams. In terms of opioids can also be given under close surveillance, but cautiously increasing dose because of the risk of constipation. And that constipation itself can trigger hepatic encephalopathy. And that's why you can add lactulose to to the post-op order set as well. Immediate release formulations are better preferred over extended dosing intervals. And the third line, so first is paracetamol, second line is tramadol, and third line could be fentanyl or morphine. But again, as I said, close monitoring of these patients must be done. So this was just the last bit of the management. And in summary, I think we need to know where our patient is on the spectrum of this liver disease, know about rebalanced coagulation, and do not treat numbers, especially in vitro tests. Involve an MDT team in management of these patients, where when decision-making regards anesthesia and surgery is confusing, and just some general principles for anesthesia and pain management in these patients. Thank you.
Thank you so much, Tejal, for excellent presentation. Now, the forum is open for any questions. Shiv?
Tejal, can you stop sharing your screen? I don't know what happened. Or am I just... I might be wrong. Yeah, back again, Yeah, got a few questions in there. I think starting off with, I think, Ashish, there was a question from Irene asking how common is CVA in these patients? I don't know why the specific question, but...
Right. Thank you, Shiv. And I think CVA is much more common in chronic liver disease. And acute liver failure is mostly... acute liver failure usually presents with herniation, cerebral edema, hepatic impairment. And the risk of stroke, which may be high in chronic liver disease, maybe about 40%, is not that much high. And in my clinical practice, that has not been a very common feature. But what I can still say is that seizure potential is something to look at post-operatively. And that is maybe due to the immunosuppressants or when the patient is coming out of this could be a problem. But I would not pinpoint to a CVA as such happening, even in spite of whatever coagulopathy is. And of course, we need to control the blood pressures and all this.
Okay, I hope that's clear for Irene. Then yes, there is a risk. There is actually a related question to this later on, which we will likely come back in a minute. And the same thing, I think Sagar Ravishetty actually wanted to know if there are any. I think what he wanted to know is about things like Mars and the other device you actually mentioned about bridging to liver failure. Are there any such machines available in India?
I think Mars has been available for a very long time. When I was getting my training done in All India Institute of Medical Sciences, Mars was being used. It did not, at least in Indian circumstances, it did not translate into any major practice. And I can tell you the reason that in Indian practice, this LDLT program is 99%. If you look at the disease donor program, it is still in a very small aspect. And these things are much like if you talk about Mars, you talk about machine perfusion. So machine perfusion in the West is coming out in a big way, and the waitlist mortality. So these things are something which are of relevance more in the Western hemisphere rather than in the Indian scenario, because mostly most of the programs are living donors. But I would say that the machine perfusion itself is gaining ground in India. We are moving towards it. We are trying to learn more about it. But definitely, the plasma exchange does have a role and is followed in more of the centers.
Yeah, I think just for the audience, MARS stands for Molecular Adsorption and Recirculation System. It is similar to what you see as a hemodiafiltration, isn't it? It does use a lot of albumin, isn't it? So the cost obviously is quite huge. Yeah.
It is also known as albumin dialysis in simple terms.
Simple terms, because it uses albumin. And that's why cost is actually much higher than your simple filtration, hemofiltration. Okay. And Dilip Singh Parmar, DSP as we call him, wants to know what is the role of NAC. N-acetylcysteine in acute liver failure? I think that's what he actually wanted to know.
N-acetylcysteine does have a significant role in acute liver failure, and in some centers in chronic liver failure also it is being followed. It will continue. For chronic liver failure, we don't use it intraoperatively. But for ALF specifically, it is started pre-op. It can be continued intra-op and the post-op, and it's because of its action on the oxidative stress and the pro-inflammatory cytokines. So helpful maybe, and then when I talk about ALF, then we're looking at spontaneous recovery. So it does help.
Yeah, I think there was a fashion, and this was a few years ago, even for this is during the time when the endovascular repairs were taking off. People were actually using it for renal protection as well. Then obviously it went out of fashion, but I think in liver disease still used. Okay. And he also wants to know, same DSP wanted to know about spinal versus general anesthesia in compensated chronic liver disease patients. I mean, what I think he was alluding to was that in spinal anesthesia, you do have hypotension, and can this hypoperfusion can lead to the ischemic injury to hepatocytes, or what he's saying is that can this probably, what he means is that is a compensated, move into decompensated with hypotension in these cases. Do you think that it's a safe option in liver disease patients, chronic liver disease patients?
I think we are looking at a guideline where we are looking at an INR of less than 1.4 or 75,000 platelets, which is very difficult to get. And I feel very wary to put a spinal block in these patients. And what I would do is do a viscoelastic test. And I would actually not look at the INR or platelet numbers, but add the VET. And if I have no other option, maybe go ahead with it, but I would take it with a pinch of salt.
There is actually related to this in a resource poor centers or limited resource centers. So there is a question later on this. So we will come to that in a minute. Dr. Achal, yeah.
Yeah, I would agree what Ashish just mentioned about a little bit being wary of spinal. Two reasons. Number one, as I mentioned, one patient, INR of 1.7, low platelet, but he was hypercoagulable. So medically, we may be correct in doing spinal if we really think that is the way to go. But we are also concerned about the medical legal implications. If there was something to go wrong, because general concept still in non-transplant colleagues is INR 1.7 or 2, so it's a contraindication. So there comes a little bit of catch for protecting your own skin. And second reason is with portal hypertension, which I did not mention because of the collaterals. So there is azygous venous system becomes a little bit distended in these patients. And we know the epidural veins drain into azygous system. So there is a high likelihood or more than normal likelihood of if you puncture the vein, so there will be more bleeding because of the increased pressure in the epidural vein. That is another thing.
Yeah. I think this question arises from the fact that a lot of people in India tend to actually use spinal anesthesia as their primary source of anesthesia for a lot of surgeries. And as you might be aware of that, now with the popularity of segmental spinal anesthesia, people actually are going up into the spine, into the thoracic level. And you can imagine that sometimes, I mean, this they might venture into this, especially in a resource, limited resource centers. And it's not just whether it's the INR or things like that, but also that, like you have said, it is a risk of epidural hematoma. I mean, it's huge. So something which you are trying to prevent, you will end up giving anesthesia for evacuation of a hematoma. So you have to weigh the benefits and risks. Yeah, so related, I think, to coagulation, we will come back again into that. But there was actually another Muthu Kumar actually asked, can we give spinal in patients with child liver C? Well, that is child purkaria, isn't it? C liver disease. Again, same thing, I assume.
Exactly. So it is all about the coagulation. And honestly, I have discussed this issue with many world experts all over, that if INR is high, but your tag or ROTEM says patient is normal, would be okay to proceed to do spinal, but everybody is wary of that. So again, because of medical legal reasons, and nobody has ventured into that.
So next question is about, I think, bleeding. And I think these are two related questions. So one is by Erin again asking if liver disease increases hemolysis. And Dilna's asking, what is the role of blood transfusion in patients who have developed acute kidney disease in a patient with acute liver failure? So is there increased hemolysis in patients with liver disease?
I would say,
am aware of such things.
so please go ahead.
Dr. Achal.
Yeah, so hemolysis. So I'm not aware of increased hemolysis in these patients. And giving blood transfusion has set guidelines with which we all are aware of. And we should be careful in unnecessarily giving blood transfusions. Number one, the volume overload and all the problems associated with blood transfusion. We are all aware of that. But as if hemoglobin is, say, 7 gram or 7.5 gram, and definitely we need to give blood transfusion. So blood transfusion saves lives, but at the same time, inappropriate use can also cause problems. And there are separate guidelines, no different whether it is a liver disease patient or otherwise.
What about then patients who develop portal hypertension? Don't they have increased sequestration of blood in the spleen? And would that, I know it's not hemolysis as such, but their lifespan of the red cells is reduced. And maybe
Yes, absolutely correct. So they will be anemic for sure. So anemia incidence is pretty high because of malnutrition plus the splenic sequestration, but there is no hemolysis as such. Yes, the lifespan of both platelets, RBC, and other blood components is reduced. And if there is anemia and we need to bring hemoglobin up, yes, there is a role of blood transfusion, but not just because of hemolysis.
Absolutely. So this was for Tejal. I don't know if Tejal's still there or trying to sort out a kid putting in the background.
My kid was screaming in the background. Sorry.
No worries. Tejal, this is Sagar Bhavisati again asking a question to you. What if decompensated patients come for elective surgery like hernia and periphery of India? And I think he's talking about workup for these patients. Can't be possible. And neither they can have like bedside tests like ROTEM. So how do you proceed with risk? Because, I mean, it's easy to say, okay, send the patient to higher centers, but they may not be able to afford to send the patients to higher centers. So is there a simpler way of actually, saying that, okay, fine, there is a risk, but
I think if it depends on how much pressure we have from our surgical colleagues as well, because these patients are definitely, the practice there would be completely different from our practice here. And I think that these patients would be definitely at high risk of decompensation, but that risk needs to be discussed with the patient, their family, because if that hernia is just the patient's not obstructed or strangulated, do we really need to proceed with this with the hernia repair? Which I think sometimes we are coerced by our surgical colleagues to go ahead with surgery, but I think we need to make decisions thinking about the overall picture of the patient, I think. So I would not go ahead with a hernia surgery unless it was strangulated or obstructed.
So if this came in an emergency situation,
yes, then you would have to go ahead.
Is there any precaution you would take to ensure that.
So one thing is you want to
doesn't go-
maintain good perfusion, right? So you want to make sure the hemodynamics of this patient is well maintained. You want to maintain higher mean arterial pressures. I don't know whether you would have an arterial line access in that place, but I would you definitely use that. Make sure the patients are volume resuscitated well in these patients. Make sure you have blood products because, as I said, though they're hypercoagulated, sometimes they can tip into a hypocoagulable state as well. So you need to have all these. If you think that you cannot do best by your patient and you cannot have all of these things ready, because decompensation can occur later. It will not happen immediately after surgery. It will happen a few days after surgery. So immediately for intra-op management, if you don't have all these resources, then maybe you should refer this patient to a higher center versus taking it upon yourself.
I'm just actually, on behalf of the viewers, I'm just going to ask you this question.
Yeah.
So we just discussed about spinal anesthesia versus GA.
Mhm.
And we know that similar to, GA also has its own risks.
Yes.
Like in the limited resource centers, they're not going to actually have newer agents. They may still be actually using low, older agents. They may not actually have, like you said, arterial monitoring itself. So, beat to beat blood pressure monitoring can be difficult. At the same time, you could actually reducing, most of the agents do reduce liver blood flow. On the other side, you could actually say that, okay, fine, I will take a risk of, doing a spinal for this case and, maintain the blood pressure with vasopressors and with fluids. So what vasopressor is your choice? What do you say, which is the best vasopressor for patients with liver disease patients? You're muted, I think. Tejal, you're muted.
I can, in the meantime, answer
yeah.
that.
Yeah.
So I would go for vasopressin and norepinephrine, noradrenaline, definitely. Even if I were doing this patient in my center, these two drugs I'll prepare before I went starting the case. So that is for sure. And number two, probably I would have a bottle or two of albumin in the room, 5%. And number three, if I don't use an line, we should have a blood pressure, non-invasive as well. Make sure the blood pressure is maintained. That is more important. And if somebody does give spinal, so it is not the spinal which is causing problem. It is if there is no spinal hematoma. Second is the hemodynamic. And we know how to manage hypotension. Even with spinal, if you start some noradrenaline infusion and with non-invasive blood pressure, probably that I would say is still the safest way to go, even in any center. Tejal, you want to add something?
No, you're absolutely right. So because of the vasopressin receptors in the splanchnic circulation, so again, access to vasopressin in those centers might be another issue.
Noradrenaline probably is much more easily available than vasopressin. What else? Yeah. So another question. I think, like I said, spinal anesthesia is going to come up again and again. So for a patient who is chronic liver disease with platelets around 60K and INR is around 1.6, if TEG values are within normal limits, are we justified in proceeding with a spinal? This is Ranjit. Wants to know.
Exactly the same question. Nobody has an answer to this because I have discussing this with world experts all over, but nobody really knows. Yes, if tag is normal, we don't go by INR to make our decisions. But since spinal is such a thing, if there is a spinal hematoma, these patients would bleed definitely. In general surgery, if they bleed extra 50 cc's, does not make much difference. But if they bleed 50 cc around the spinal cord or in the brain, that makes a huge difference. So we should be careful. But yes, if there are no options left and surgery needs to be done, tag normal, I think that would be our safety thing for medical legal purposes as well. So we will not go by INR, we go by tag. Yes, I think answer would be careful, but yes.
So I think one more thing I would like to ask is that in the peripheral centers or centers where there is limited resources, one thing they do actually have is whole blood. Rather than components, they do actually have whole blood. They may not have access to albumin, to plasma, and to factors, but they might have access to whole blood. Do you think that it is okay for them to actually go ahead and prophylactically transfuse whole blood in such cases where they might think that, okay, this is going to be protective? Achal or Ashish?
Yes, again, it boils down to the choices one we have. And if there is no choice, yes, of course, whole blood can be used. But as three of us all mentioned, there is no role of preemptive use of blood products to correct the coagulopathy. That's the numbers. We are trying to correct those numbers, which may be counterproductive by increasing the portal pressure by giving more volume to this patient. But as if patient's hemoglobin is 6 or 7, definitely go for whole blood. The aim is to increase the oxygen carrying capacity, not to treat an INR. So that is my short answer to this.
Absolutely.
I agree with that, Dr. Thier.
Thanks, Ashish. You probably have more experience of all this. You know, I don't think we have anyone who's actually been working in these kind of centers here, but I think in the audience we have quite a few people who work with limited resources, and I think these answers are going to provide them some confidence in dealing with such patients. So into similar, I think there was some comments and some questions as well. Dr. Hemant Vaikar, who is a senior faculty with us, and he's asked, is the role of tranexamic acid to reduce chances of epidural hematoma in patients who have been given spinal? So, so again, spinal again. So would that actually have any role in general as well? I think as well, say if the patient is having his surgery done, would he prophylactically use tranexamic acid in these patients?
And the short answer, no. We should be evidence-based medicine practitioners. And if we have the availability of TAG or ROTEM, and if the patient is showing fibrinolysis on that, definitely tranexamic acid has a role to treat that fibrinolysis. But preemptive, I don't think so. Because we were using preemptive tranexamic acid for all our liver transplant patients, but which we stopped about 5 years ago. So no preemptive, no standard. One size does not fit all, and we go by what we see. And I personally don't think it is going to help.
And I think,
Sorry.
sorry.
No.
Yeah.
I think this tranexamic acid is an overrated ampule. It's actually not required in more or likely any situation.
Also, there have been, also with this use of tranexamic acid, especially in previously when we were using them in very high doses, there have been catastrophic, in this group of patients, there have been catastrophic clotting events or thrombotic events. So using them, as Dr. Dheer said, without evidence of actual fibrinolysis, we should not be using them, at least in this group of patients as well.
And I think that's where I think your bedside, measurement of coagulation with ROTEM.
Yeah. If I may add to Hemant's question, so we don't use tranexamic acid just for spinal reasons. But if patient is undergoing hip replacement or knee replacement, we give all our patients tranexamic acid. I don't know, Shiv, what is your practice? So this we have been giving for many, many years now. Tranexamic acid for hip and knee replacements, and for any surgical patient who is expected to bleed more.
That's true. I think with CRASH2 trials being used as a reason for using tranexamic acid left, right, and center, I actually tell the surgeons, do you really need to actually use it? I think if we go blanketly actually giving it, yes, I mean, hip surgeons, knee surgeons. Well, previously we never used to use for knee surgeries, and they started asking for knee surgery as well. But looking at specifically, I think this group of patients, I think, like I said, there is probably no role in it. So I think it's not going to make Spanan any more safer by giving tranexamic acid. I think that is the bottom line.
Yeah.
And I can share a very difficult experience I had post-COVID. So what happened in my center was that the brands of tranexamic acids changed. And we gave a regional, and as a protocol, we were giving tranexamic acid and went into anaphylactic shock. I was barely able to intubate that. So that was something which that has changed a little bit amount of practice, and plus it was a change in the brand at that time. So we raised an incident at that time.
And I'm also of the principle to use drugs or agents whenever they are required, not blindly, not to prevent so many things. But if required, absolutely yes. But not if they are not indicated.
Yes, less is more.
Less is more. That is, you learn it with experience.
Yeah.
It doesn't come easy. It doesn't come. It's hard. It is hard. It's easy to actually just give everything and assume something will work. So less is more comes with experience and age, probably. I'm not saying that Tejal, you are young. But that's a very good, I think, comment. I think before I go into some other questions related to that, there was one more question. This was about, I think, tips. Yes, Muthukumar wanted to know, what anesthetic precaution will you taken for tips procedures?
Okay, so in our institute, whenever we do tips, okay, though if you read an article on tips, there will be mentioned that in some centers we do it under sedation, but in our center we don't do it under sedation. We always intubate these patients. They're at high risk of aspiration. Even ventilation in these patients can be difficult. For example, I will just give you one of the experiences that I had with a patient. So usually when we intubate these tips patients, they come into interventional radiology. You're intubating them in an upright position because using all the precautions for aspiration. But the moment that is done, when they go on the table, they're completely flat. And now when they're completely flat, the lung mechanics change. It can be very hard to ventilate these patients. It is very uncomfortable for them because of the big protuberant abdominal filled with ascitic fluid. So we always do a general anesthetic for these patients. We've also had, I think, before I was here, 3 or 4 years ago, there was a patient who developed a peritoneal hemorrhage after TIPS procedure, and that patient died. When I was doing one of the TIPS cases, sometimes the radiologists are not very speedy. So this patient is having a general anesthetic for 4 to 5 hours. Ideally, a procedure should be done under 1 hour. And this patient decompensated post-operatively as well, my patient, where they had to work her up urgently for a liver transplant, but then she recovered a few days later. So every anesthetic that we do is not without risk. And when you cannot ventilate these patients, they are a bit hypoxic, they can be hypotensive because of the ascites. So it can be quite a challenging procedure if it's not done expeditiously by the surgeon.
You're right, Tejal. Our center there they used to take few hours to actually do this, and all our cases were intubated. Some of these patients actually went from intensive care, so they were already intubated.
Okay.
They're not relying, so it was so yes, I think sedation, even if your radiologist or the interventional radiologist friends are actually very, very quick, I think still better to be on the cautious side. Just intubate. You don't know what can go wrong in these cases.
Yes.
Yeah. Okay. What else was there? Tranexamic acid we've already discussed. Yes, there was a question about would you use 5% albumin or would it be 20% albumin? Which to choose, and what is the basis? That especially during transplant. This is Rishikesh Shivatkar, something. So
Yes,
yes, Achal, 5% or 20%.
it is about the volume. 5% we have available easily in our hospital, so we do give 5%. But yes, if it is 25%, it is about the amount, how many grams you want to give. And this is related to the ascites. I think that some centers have this formula that if you drain, the surgeon drains, say 500 cc of ascites, give 2 grams, something of that sort. I'm not actually know that formula. So it's related to that. But I electively give, personally, this is my personal experience, may not be based on any evidence, but I do like to give these patients albumin. Number one, their albumin is low because of chronic liver disease. And number two, the ascites drainage will precipitate them into acute renal failure, the AKI, or the hepatorenal syndrome. And number three, there is evidence that something like glycocalyx, if people know about it, which is the smooth wall inside the vessels, and that is have a protective role. And albumin has been shown to protect that glycocalyx. So for that reasons, I personally do give. Does not make difference whether it is 5 or 25%. In our hospital, is 5%, so I'm using that. And instead of giving more and more of crystalloids, I would end up giving some kind of colloid, which is not blood transfusion.
I mean, I think this is not related to liver disease as such, but Dilnas want to know what are the guidelines for using tranexamic acid in laparoscopic surgeries. As far as I'm concerned, we don't use it regularly. We don't give it to these patients. I don't know if others have any other opinion about it.
You mean to say albumin for non?
No, tranexamic acid.
Oh, tranexamic acid.
In patients with laparoscopic surgeries. I
No
think
way.
it's not related to chronic liver disease or acute liver disease, but just to as in general. We don't have.
Only one place where I give routinely is cardiac surgery. Because there we know that because of the stress response surgery, inflammation, there is fibrinolysis. And for liver transplants, we do TEG. And if the post-reperfusion phase shows some fibrinolysis, then I probably give a gram of tranexamic acid. Apart from that, not much role.
So I think related to fluids, again, there's one more question just popped up. It's from Muthu Kumar again. He's asking about use of the crystalloids. He asks, is ringer lactate okay for patients with liver failure?
Should I be able to?
Yeah, Ashish, yeah.
So I'll say that before my fellowship in Canada under Dr. Deep, so I was working here in this center, and it was like crystalloid.
Yeah.
When I went there, I saw a different set of practice, and then when I came back to my, so I changed that practice, and then there was a lot of resistance in use of albumin, primarily because you are causing a lot of damage to the exchequer, and using a lot of things. But what I saw was a definite improvement in the post-operative morbidity of these patients. We used to have a lot of patients with third spacing, scrotal edema, mobilization being a difficult thing. And the moment we changed over to albumin, it just shifted the balance. And so I personally use a lot of albumin, which is in the mandated levels. And I am really a great fan of using albumin. And as far as ringer lactate, I think it does not have any role in liver transplant. I think we're more towards balanced salt solutions. And I always remember one thing which Dr. Dheer taught me is that white fluids are the killer fluids. Actually, that is true. So I would say.
Say again. I didn't catch that last part.
White fluids are the killer fluids.
White fluids.
Yeah, white fluids means a lot of saline, a lot of ringer. So you change that shift towards albumin and the blood products and top it up with a little bit of crystalloids. So
if, just related to fluids, we know that these patients can have hyponatremia is very common. And so I think it was discussed about using hypotonic saline. I think it's Ashish, you actually talked about. So would you actually, again, consider this
Not
Instead-
it is just, I think, just a preoperative kind of a critical care issue where you
Hmm.
might try to bring up.
Hmm.
The guidelines have changed, especially in liver transplant. We don't look at 12 milliquins, we look at 6 milliquins in 24 hours.
Hmm.
And the sodium level where we take up these patients have also been debated a lot. Maybe you could take an emergency patient for 120. The only
Okay.
thing which has to be kept in mind is your shift is not more. Now, how do you manage that shift? You could have, in Indian settings, we don't have those things, but I think renal replacement therapy itself helps in the ALF patients. That's one thing.
Hmm.
So I would be more worried about the shift at that point. And albumin, which we get, has a lot of load of
Sodium. Yeah,
Yeah.
that's true. I think that does actually help in that. So I'm really surprised that your limit for sodium is 120. Is that true for everyone?
I think it
Achal,
is one of the most,
I mean,
Limit means
I mean, just now Ashish mentioned that you're okay with patients having a sodium of 120. I think is that kind of a cutoff point. But if it was, for example, somebody who is coming for surgery, a chronic liver failure patient, coming for a surgery, what would your limit be? Obviously, this is different for renal transplant patients, but if somebody is coming for a usual surgery, what would be your cutoff point for sodium? And do these patients actually tolerate low sodium better? Renal failure patients tend to tolerate higher potassium. Do the liver failure patient tolerate lower sodiums? Because I would be worried at sodium of 120.
Yeah, personally, I will also be worried, and my cutoff would be 125.
Hmm.
And of course, it should be as normal as possible, but we don't have the perfect world all the time. So my cutoff in general is 125 for even for liver or for other patients as well. And we tend to give a little bit of saline to bring it up to 130 or so. And to come back to your first question, whether these patients tolerate hyponatremia, I don't have an answer to that. Maybe Tejal or Ashish can mention that. But this hyponatremia basically is because of ascites or because of extra fluid. It's more of a dilutional thing.
And it's
But
chronic
that,
in these patients.
That's the thing. Yeah,
yeah.
exactly. Because patients who are on diuretics, we do see patients who are in chronic hyponatremia state. So we don't need to actually correct it so quickly. So similarly, I think we tend to tolerate that. Yeah.
And I think 120 is also the cutoff below which all the CNS symptoms would start, like seizures. So that's why 120 is a cutoff where you would not want it less than 120 as well. So
That's true. I mean, there are actually, I think question-wise, I think we have taken up most of the questions now. And lots of thank yous to Ashish, to Dr. Achal, to Tejal, and everyone for a wonderful presentations and very interactive session as well. And we actually took up each and every question which was in the chat box. And we have around we have crossed 300 views already. So that's actually excellent. Just shows the quality of the education we provide. Anything last remarks? We can start off with Ashish.
I just want to mention one thing
sorry,
about hyponatremia
Yeah,
is that even FFP has a high sodium load. So if the patient is severely hyponatremic and for any reason that you have to give FFP, be mindful because you don't want to bring up that sodium very quickly for risk of CPM or central pontine myelinolysis as well. So FFP, albumin, they all have a lot of sodium. So just to be mindful.
Absolutely. Absolutely. So we'll start off with Ashish before we actually end this session. Last words of wisdom, Ashish, for our listeners.
I think I can only say that liver disease is something which is not to be afraid of while you give anesthesia for. You just have to be more evidence-based and look at the parameters in a way that you just don't look at numbers. Because there has been times where I've seen that people run to correct those parameters look at an INR, they go horrific about just giving something. So everything has changed from preemptive to perioperative care. So I would end by saying that it's general anesthesia or spinal anesthesia. We won't likely just think of it as a more something which we have to encounter now, much more common.
Thank you. Thank you, Ashish. Dr. Achal.
I can suggest to those people who work in the resource poor centers, if they can make note of few drugs like vasopressin or terlipressin, which is easily available in India, terlipressin especially, or those kind of small drugs, even norepinephrine if they don't have, and pressurize their administrators to buy these drugs, which are life-saving drugs. And knowledge is power. So use your knowledge and evidence-based medicine and do whatever best you can provide in that resource poor, resource limited center. That is my take home worldly advice.
Thank you, dear Achal. Tejal,
So
last and final words.
I have nothing much to say, but because they both spoke. But I think it's very important to anticipate. So since we had this big session today, more awareness about these patients and just learn what to anticipate in these patients when things go wrong. So I think that's important as well. Yeah.
All right. Thank you very much, dear Achal, Ashish, and Tejal for this wonderful session. And it's been almost 2.5 hours exactly.
Very productive session. And thank you again, Shiv, for providing this platform. This is a wonderful, I would say, gift to everyone. And I appreciate your efforts and dedication for this. And those who are still listening are involved. We are meeting in November. So if you have any questions, any doubts, meet us there and register for the conference. Thank you so much.
Thank you again for the opportunity.
Thank you. Thank you, Shiv. Thank you so much.
My last words, I think this wouldn't be possible without such a wonderful faculty. So thank you for giving your precious time. That too on a weekend. And especially Tejal with your small kid.
No, I thoroughly enjoyed the session. It was very good.
Thank you. Thank you, everyone.
Thank you, everyone. Thank you so much. Thank you.
Take care.
Thank you.
Thanks, Tejal. Thanks, Ashish. Talk to you later.
Thank you, sir.
Bye, Shiv.